Just going to try and give a really quick update here on the current epidemiology, some predictions, a little bit of laboratory, and a little bit on vaccine pertaining to the SARS-CoV-2. And what I want you to take away from this is actually a little bit of the basics of our common seasonal coronaviruses. Concepts of infectious disease epidemiology, existing data sources and models for SARS-CoV-2, the role of laboratory, and then just very briefly on some issues with vaccines. So we're going to start out with something that we all should know a little bit about, our seasonal coronaviruses. There are currently 4 endemic human coronaviruses that we see actually all the time in our practices. Just very quickly, it's 229E, HKU1, NK63, and OC43. But these are really common in our communities and in primary care practices. They are found across all ages. They're highly seasonal, and there's a tendency for co-detection with other viruses. And this is work that we're actually just completing right now. I'm working with a medical student, Julia Wilson. And for those clinicians and residents out there who practice at St. Mary, she's a 4th-year medical student and daughter of Jon Wilson, the pulmonologist. But OC43 is the most common, representing almost half of our infections and that we see in the community. And we see this common across a lot of different populations. We've had the ability to look in different platforms. We run a project down in school-aged children in Oregon. We've looked at primary care patients, and we've looked at long-term care facility residents. And the bottom line is, of the viruses that we detect, coronaviruses are one of the major players. Of interest is the commonality we find in long-term care. When we started this project, I was expecting that we would find primarily a lot of children with coronaviruses and less so as we get older. But as it turns out, we see the seasonal coronaviruses across all ages. And this may become relevant a little bit later on. But we don't tend to see a picture where people have a lot of disease in the first 10 to 20 years of life and very little thereafter. We see a picture that is kind of ubiquitous throughout the entire age range. These viruses tend to be highly, highly seasonal. The peak for 3 of the 4 subtypes or serotypes tends to be in late January, and the 4th, 229E, is a little bit later at the end of February. But if you take a look at this diagram, week 27 is first week of July. Week 26 is the last week in June. And we virtually don't detect these viruses during the late spring and the summertime. These tend to be what I would call fairly promiscuous viruses. They tend to have co-detections a lot of the time. They tend to circulate with other viruses. But if we take a look, the common ones out there are influenza and rhino viruses that we find in one individual evidence of both viruses occurring. We use the term co-detection instead of co-infection because infection is a little bit harder thing to prove. Next, just going to turn attention a little bit to the clinical aspects. These viruses tend to cause usual respiratory symptoms, a wide spectrum of clinical severity. They do cause influenza-like illness, and we'll talk a little bit about the role of the strain or serotype, sex, co-infection, and age. If we take a look at again, the seasonal coronaviruses, boy, they show us the typical things we tend to see: cough, nasal congestion, rhinorrhea, and sore throat. And in fact, 95% of cases with coronavirus will have at least two of these common symptoms. Interestingly enough, about half of individuals will have a fever, and almost half will have an influenza-like illness. What you're seeing right now has not been presented to anybody else, so this is brand new data that we've just pulled out of our large data sets. But before I got started with this, if anyone had asked me, I would have said that coronaviruses tend to cause mild upper respiratory tract infections, period. I'm actually very surprised that about half the time we get a flu-like illness with these. And this came as a surprise, I think, to us. They tend to have moderate severity. About 7% are going to be severe cases, and range temperatures from 96.8 to 104 with a mean of just slightly over normal. And then when we take a look at those individuals with a flu-like illness, or ILI, we find that it depends on the serotype and the presence of co-infection. These are big drivers. But it turns out, and again, this is surprising, that age does not make any difference. So even old people getting this or these viruses will tend to have a flu-like illness. So the implications right now for looking at the common coronaviruses for SARS-CoV is the potential for high seasonality for SARS-CoV. We don't know if we're going to see this drop down during the summertime and pick up during the fall, or if it's going to continue burning through our population. I can tell you that with Australia, they're having widespread transmission, but it is not real heavy. And the people I know down in Australia are very, very concerned about what's going to be happening in the next 2 to 3 months. There's, when I take a look at the seasonal coronaviruses, there's really a questionable durability of immunity. We don't see a pattern like we see with measles, where people see this disease once or get vaccinated once or twice as a child, and they're immune for life. What we're seeing with the seasonal coronaviruses are people are likely getting reinfected throughout their lifespan. And think of this more as RSV, for example, or influenza. There's wide clinical presentations, and this is very similar to COVID, where we go from asymptomatic and low symptoms all the way to people on ventilators and dying. And then the other thing is the potential for virus co-infection and co-circulation, and particularly with influenza. So I will stop there just for a little bit and see if there are any questions on that first part.
Jon, it's Allie Couture. Can you hear me?
I sure can, Allie.
So when you say that there's the ability for the seasonal coronavirus to get kind of reinfected later in life, is it with a different strain, like one of those other, 3 strains, or is it still like the exact same one that even if you've had it, before in your teens, that you could get again in your 40s, 50s?
Well, great question. And we end up having one of the largest sets of consistent data for coronaviruses anywhere in the world, from what do you guys do in clinic and our orchard study and so on. What you would expect is to find different viruses occurring maybe at different points in life. And as it turns out, that if we look at each segment of life, we find pretty even distributions of all 4, which would indicate to me that people might see and get infected with these viruses repeatedly through life. And that just, I think, is of significance if we start talking about, well, what happens if you come down with the SARS-CoV-2? Are you going to be immune for life or not? And the answer is nobody has a clue at this time. I'm going to move on just to some really basic information on infectious disease epidemiology. And I wanted to touch upon this because it really becomes relevant for discussions going forward over the next 12 to 18 months. And I'm just going to touch upon some of the necessary conditions for outbreaks to occur. To actually get things going, you have to have something take off. With SARS-CoV, it looks like this was what we call a zoonotic jump coming from an animal to a person. The coronaviruses are found in a whole lot of different species, both mammals and others. And every now and then you have a transmission jumping from a non-human host to a human. With MERS, it appears to be camels. With SARS-1, it looked like it was civet. And the SARS-CoV-2 appears to have a lineage of bat coronaviruses, but may have come through a different species, a pangolin. But on top of that, with this global connectivity, you have the potential for creating immigrant effects where you have a case end up within a remote community and serve as the spark there. You have to have the susceptible population. And this is where there's a definite role for a novel virus because there is no pre-existing immunity. There's no past exposure, though we wonder if there's any cross protection from similar viruses. As far as we know, there is not, but that's an open question. You have to consider the host issues involving immunity and comorbidities. And the other thing to keep in mind is right now we have no available vaccine to affect the pre-existing immunity. Environment is really important for many viruses. Influenza is a big one where temperature and humidity have a lot to do. When we look at the other coronaviruses, there appears to be a definite affiliation with cooler and drier cooler temperatures and drier conditions. And whether or not this plays out with the new coronavirus, we do not know. I put down the anthropogenic risks because we know, at least from studies, that people who are living in areas with things like air pollution have appear to succumb more easily to SARS-CoV-2. And then we have the long-term trends, which include things like climate change that may play a role in some of these viruses. The enhancement of contact is really important. And this is the target of our social distancing, but these can come in a whole lot of ways, from the public schools, employment contacts, the way we commute, confined spaces, and us aggregating over holidays. One of the big concerns in China was the acceleration of SARS-CoV-2 during the time of the Lunar New Year, when a lot of people tend to get together. So this leads me into just some very, and I apologize, but some very basic epidemic math, because it's very relevant. Classic equation is the number of cases at some time in the future is related to the number of cases today or at time zero. And it's an exponential function that takes into consideration this thing called R, the intrinsic rate of growth, and T, the number of generations or the passage of time. And the next slide here just shows the US cases through today, which shows what looks like a pretty nice exponential curve. But let's just take it a little bit further. When we talk about the intrinsic rate of growth, there's something called R naught or R sub zero, and that's really the intrinsic rate. And that's what happens if you take a case in a randomly mixing group of totally unimmune people. And we can consider this as the number of new cases that are generated by each currently existing case. And if you're constantly randomly mixing in the sea of no immunity, it allows this virus to spread unchecked. The measure, the way we can calculate R is by taking basically the logarithm of one generation divided by the number of cases in one generation divided by the number of cases in the previous generation. And let me just show you what that means. So if you have a virus that generates 2 new cases for each case, after 4 generations, you have 16 cases. If it's 3 new cases per case, 81, 4, 256. If we look at things like measles, that's somewhere between 12 and 19 new cases per case if you're in this population totally non-immune. So what that does is it leads to exponential growth. You keep on getting with each generation more and more cases, which would go on ad infinitum, except that R will rapidly decline after a period of stability. And this is because eventually you run out of susceptible individuals in that population. And so the more people who become infected and hopefully immune, it takes kind of that drive away. And because of that, you get your classic epidemic curve. You have that rapid exponential growth, slowing down, hitting the peak, and then dropping. So when we start talking about social distancing, what we're really talking about is reducing that intrinsic rate of growth. This is just some models I built. And if you had something that had basically 2 new cases per case, you can see a really rapid spike up and down. But if you can drop that down to about, I show different levels here. And what you end up doing is dropping down the amplitude and pushing things out into the future. And that's the whole idea behind social distancing. We want to reduce that intrinsic rate of growth. Another way we can do that is to have some sort of way to affect immunity. So this is a similar type modeling, but looking at what happens if you have 0, 5, 10, 15, all the way up to 35% pre-existing immunity. And this is modeled off of influenza, but the same thing could be said about coronaviruses, that the more immunity you have, the less amplitude and the later. So whenever you hear about people talking about flattening the curve or pushing the curve into the future, that's what they're talking about. So I think I'll stop there and just see if there are any questions at this point in time.
Just about the time and the number of generations, do we, the question, depends probably on where you live, but do we have an idea of where we are at, for Wisconsin versus, U.S. versus the world?
Well, that's really very, very challenging because there are a lot of different models out there, and a lot of models say different things, and nobody's really comfortable with any one. So I'm really reluctant to go in that direction. What's been bantered around is that for Wisconsin, we might not be at a peak for another month or so. But again, the model that people have been using mostly has been one out of University of Washington, which had very early spread, but they're finding that that doesn't really apply very well to other places in the country. So I'll talk just a little bit more about models in a second here. And Actually, what I'm going to start out with is just the incredible explosion of information. This is a PubMed chart that looks at the number of articles per year. And you see with the arrival of SARS back in 2003, there was a big jump up on articles about coronaviruses, SARS, MERS, whatever. It shot up, dropped on down. We had the emergence of the Middle East respiratory syndrome. A similar wave came up. And now with COVID-19, in just the first 3 months of 2020, we had almost 2,300 publications out there that were recorded by PubMed. So it's near impossible for anyone to keep up with the amount of information out there. That being said, I'm just going to give some examples of tools that I think are really well done. The first is the Johns Hopkins website that provides really up-to-date information in terms of number of cases, number of deaths, the amount of recovery. And if you look at the left-hand side column, you can drill down, click on the US, and it has administrative 0, 1, and 2. And you can actually really get to statewide and countywide data off this. It also provides an ability to look by jurisdiction at some of the epidemic curves and gives you the ability to convert them into a logarithmic curve if you're so inclined. So this is one that has been very, very well done. When we look at the United States, this is actually brand new, came out and was started yesterday, or a couple days ago anyways. But CDC has in the past had the flu view, and this is modeled after that as COVID view, but provides information on a whole lot of different ways of looking at SARS, coronavirus epidemiology, and surveillance data. And I just copied a couple things from here showing, for example, on the graph on the right-hand side, upper, showing the percent positivity for public health lab samples, and jumping up to almost 15%. Also down below, the number of specimens being reported in clinical laboratories with the positive findings and the percent positivity. But so this is very good, reliable information. Closer to home, the Wisconsin Division of Health has similar information on a website. And then we can actually even drill down to Dane County, where we have information that is available and updated on a daily basis as well. So for example, looking at Dane County, 310 cases so far, 11 deaths. We've had 5,673 tests performed here. So this just is an ability to keep abreast of the information. I'm going to just move to a couple models that I want to share with you. This came out of a program put on, a webinar by the Association of Public Health Laboratories in conjunction with the National Academy of Medicine. And this is from Mark Lipschitz, who is a modeler at Harvard. And when I sat in on this, I found this to be actually very sobering. And so I'm just going to show you, I'm not sure if you can see my pointer up here, but the diagram on the upper left shows what happens if you have a 4-week period of social distancing. So school closure, business closure, and recommendations to keep your distance. And it shows with that, 4 outcomes. or actually three outcomes. One outcome is the no intervention, and then the intervention is with a month-long or 30-day period of social distancing. And then it gives three scenarios where you have a 20, 40, and 60% reduction in that basic reproductive number. And you look at this and go, you know, with a 30-day, you delay things by a bit, but you don't get much out of it. Heading over to the right is similar modeling for an 8-week, and then a 12-week and a 20-week. And what you find is the more effective you are in reducing, the more effective your social distancing is, you do a really good job of pushing things into the future, but unfortunately you don't do a very good job of actually lessening the number of cases you're eventually going to get. And so if I show you the one on the lower right hand, with a 20-week enforced social distancing that's 60% effective, what you end up doing is just really shoving that peak into November and December. So kind of keep that in mind. The next one, what I just showed you was modeling without seasonality. And then if you put in seasonality, so if you assume that this new virus is going to transmit better in the fall and winter time, you get a little bit different answer. So that 1 month or the 8-week is relatively effective in the short run, but then you start seeing that really big recurrence come the autumn and early winter. And so I think that's what I'm particularly concerned with here. So I'm going to stop there and just reassess if there's any questions.
Hey, Jon, this is Patricia. We are listening to you, and I have your slides up at Wingra. So with the best of your knowledge, with what you are telling us, what will be, let's say you were doing a press conference, what will be the recommendation for the U.S. and for Wisconsin?
Well, I think what we're doing right now is really paying off. I think Wisconsin was very preemptive with school closure, number one, followed by large assembly avoidance, followed by small assembly and business closed down. And I think we're really having a big benefit right now. We're doing a great deal in terms of preparation, but we're not seeing a huge amount of cases. It's growing not exponentially here, but more linearly. And I think so we're seeing the benefit. That being said, we may pay for that benefit later on in the future. And so if you were to put me on the, make me take a stand, I'd say it's very likely we will see things slow down over the next 3 to 4 months. I think we'll continue to have a lot of cases here through April into May, and maybe slowing down during the summertime. But I really worry about when we get to September 1st and the schools open up again, and we have children together. That may be a really potent driver. And then bringing in the cooler, drier temperatures of autumn, we may be in for a significant surge come October, November, December.
Any chances of a vaccine by then?
I would say absolutely not. And I'll get to vaccines in a little bit here. So,
any chances that what they are doing with the serum of the ones that were infected before will produce anything significant to treat the others?
Well, that's going to be a good tool, but it's going to be very limited. And so one maybe hopes to be able to produce in mass quantities monoclonal antibody. So all this is going to be beneficial. We hope we can develop antivirals and so on, but all these things take time.
Jon, this is Ildi. Apparently Evers is shutting down the state parks as of tonight. Do you think that is going to make any difference or no?
Well, it's going to make difference in terms of all the vandalism going on right now.
Yeah.
I don't know how much utilization there are of state parks going on right now, but so if I can step back a little bit, one of the things that we saw with the school closure is we have pretty good evidence that it made a profound effect on influenza here. And so it really has an effect on transmission of respiratory viruses. We don't know to what extent children are a driver of SARS-CoV-2, but I assume they probably are a major driver. But in terms of other shutdown, schools are the easy one and the big payoff. Closing or suspending large gatherings, unfortunately, except for voting, is a really good idea to limit. And so I think everything we're doing helps to lower that basic or that intrinsic rate of growth. But there's just limits to how long you can do that and what happens when you relax. So I think right now across the news media, across various experts, people are saying, you have to be careful when you start relaxing these, because as long as there's a lot of people out there who are not immune, this has the potential to explode back.
Jon, this is Sean Duffy. I just had a question about, in with the seasonal patterns of virus. So, is there just sporadic cases all year long that is serving as a reservoir that then you start to explode again when conditions are more ideal for widespread infection?
Yeah. Wonderful corollary is the 2009 pandemic of influenza H1. And what we saw, the first cases were reported in San Diego in the latter part of April. It really took off and was prevalent all across the country in May and was really accelerating. And then, miraculously, all the schools shut down for summertime, and H1N1 went away, except if you were doing widespread surveillance, you were picking it up virtually every week during that summertime across Wisconsin. But the conditions weren't such that it was conducive for widespread. Once schools got started back in the fall, it exploded, and it was early October that Wisconsin hit the peak that year. And so there's this real combination of schools, of association, and probably some component of weather. But when we see things, quote unquote, go away, they don't go away. They just go into very low levels of transmission, but sustained transmission.
So then what happened with SARS-CoV-1 or MERS?
Yeah, well, MERS is still chugging away out there, but basically the driver of MERS is if you're helping camels deliver their calves, you're at high risk. Really high levels in camel amniotic fluid. But it doesn't transmit human to human very effectively. SARS-1, They say there was really good public health interventions, and I don't quite buy that one. I think it was just a different virus that maybe was a little bit more fastidious in terms of the environmental conditions it needed. And it may have just gotten too warm for it. I'm not sure.
So at this point, the thought is that it would have to be zoonotic transmission again to to reestablish and start another outbreak of that
That's,
one.
yeah,
Whereas this one, whereas with COVID-2, it's now there's a human reservoir. It's going to be with us.
yeah. Well, I think most people think this is going to be our fifth seasonal coronavirus eventually. Okay, I'm going to move on just a little bit here. I just have like 3 or 4 more slides. So with laboratory considerations and vaccines, our current testing is by real-time PCR or other molecular techniques. And these generally have very high sensitivity, very high specificity, but unfortunately, they've not been in very wide use just because of the lack of supplies. And as of now, there are multiple swab types that have been FDA approved for these tests, including just a simple nasal swab. FDA and CDC recommend against patients self-swabbing their nose. We have data to show that, at least for influenza and other things, that self-swabbing works just fine. But there are a lot of gaps out there because we have very little testing in communities and for individuals who are at lower risk or have low symptomology. So we really don't have a clue as to how much SARS-CoV-2 is out there. The other thing is we have very little information on the period of shedding. In the news this morning were, I believe, 51 individuals in South Korea who were COVID-19 patients that were in the hospital. They were found to be virus-free on 2 successive PCRs, and then 51 are now positive again. And so we don't have a good idea about how long people potentially are shedding. Our very first case in Madison, coming from China, continued to shed virus at fairly high levels for 30 days. So those are some of the laboratory considerations. When we talk about serology, it's going to be very essential to have antibodies out there, but these are under development. We need to better understand the trajectories of IgG and IgM to better understand the timing of testing. That there is a lot needed in terms of the sensitivity and specificity, and whether or not there's cross-reactivity with other viruses, particularly the seasonal coronaviruses. We right now have a tremendous gap in our ability to evaluate background immunity out there. We don't have any ability right now to say what part of our population is immune, or after this wave or a future wave, how many people are immune. And then the thing you have to understand is for vaccine development, you really need a reliable serological marker for a correlate of immunity. You need to be able to test. You don't take your group of volunteers, give half vaccine, half not, and then expose them to coronavirus. You have to have some sort of correlate of immunity. And so we really need much more in the way of antibody evaluation to learn about that. The other thing for laboratory consideration in vaccines, just the challenges, just keep in mind that most of the new vaccines you see out in use right now, so for example, the Shingrix for shingles or the HPV, these typically take from concept to market about 15 years to develop. That just coming up with the antigen is the easy part. The hard part is assessing the safety. And the safety can't be done just give it and look at somebody for 3 days. Technically, we tend to look initially at a 42-day or a 6-week window, and most safety assessments go on for a full year after that. There's a whole issue of efficacy and effectiveness. How well does this vaccine protect against, or how well does it boost antibody, but does boosting antibody actually translate into less clinical disease? There are issues around the immunogenicity, the reactogenicity, or the side effects, and the whole issue of immunosenescence. So is this going to be a vaccine that we have to boost somehow, particularly for the older people who are experiencing most of the morbidity and mortality? My guess is with a vaccine like this, it may take 2 doses. It may need to be adjuvanted. We don't know what the timing of those doses are going to be. And then we have no idea about the durability of immunity. So those are all really important questions out there that we have a lot of question marks around right now. I'm going to just finish with 2 slides here. This is just some modeling I did probably 3 or 4 weeks ago, but just asking the question, what percentage of our population needs to be immune or recovered for SARS-CoV-2 to actually go away? And this is dealing with the best guesses of the basic reproductive number. And the quick answer is somewhere around 55% of us have to either come down with this and recover or be vaccinated before you have that herd effect kicking in. And so I have no idea where we are right now. Across the world, we have 1.5 million people known to have this, and probably a whole lot more that have had it, but we're nowhere near a population immunity that will have much effect on transmission. And the last thing I'll just leave you guys with is just 2 things that were out pretty recently here. This on the left is out this morning, looking at the disparity across the world in terms of who gets the supplies. We're having a lot going on in the United States, but I assure you that across India and across Africa, this is going to be incredibly devastating, where the discussion of reusing an N95 doesn't come up because there are no such things there. The other thing, this is from Milwaukee, but we're seeing such an incredible disparity in terms of morbidity and mortality with this virus, and particularly hitting communities of color and impoverished communities. So I'll stop there and hang around for questions if you have any. So thank you much.
I just had a question about, with typical coronaviruses, I know this was somewhat asked, but is there a turnaround time to when you can be reinfected again? For example, if you had a, previous coronavirus, how long are you protected from it with the other strains that are in circulation right now, other than COVID-19?
I don't think anybody knows. And we're working on just a basic epidemiology and clinical paper on seasonal coronaviruses right now, and we have to go back about 3 to 4 years to find the most recent epidemiological paper, which comes out of southern China. There's just not a whole lot of work out there, so I don't have a good answer for you.
John, this is Tom Hahn. Based on the 4-week, 8-week, 12-week, 20-week curves you showed, do you think that it could, and this is just, based on benefit and your thoughts, do you think it could be beneficial to have another, stay-at-home mandate and/or school closure in the fall?
The more one predicts, the more one is going to be wrong. But I would not be surprised if we end up seeing a need to again stop or close schools down and reinstitute the social distancing come autumn. That's if we're real effective on keeping everything low through the summer months. But again, I think it's going to take until we are able to have sufficient immunity for this to keep it from popping up again. So whatever we're doing right now, we better kind of at least keep in the toolbox and be ready to reuse again if we find that we're doing a much better job of slowing things down. Because until we get to a certain point of population immunity, the potential is for this to come back.
It looks like someone had typed a question if there's a strategy to be worked on, or a strategy being worked on to limit a fall or September explosion that you know of, or any ideas.
Well, part of the whole approach right now, you keep on hearing about flattening the curve. And what you're doing is trying to keep the peak of the curve and the tip of the iceberg with need for ICU and ventilator space, keeping that where the amount of need is less than the amount of supply. And one way to do that is to have this continue, but at a lower level, where you might constantly have somebody in the ICU on a ventilator, but you don't have 40 people needing the ICU. You might have 1 or 2 at a time for a prolonged period. Unfortunately, what we do now has effects into the future. And the more cases you avert now, the more susceptibility there is for a future time. And so it's really a difficult situation.
Hey, Jon, any words of encouragement?
Well, yeah, I would love to go back to the island we were at in Mexico. No, I think the thing about it is the social distancing within reason, the use of masking is going to be beneficial. And we've seen an awful lot of our population become adherent to very new and different ways of doing things. So I think that's very encouraging. Keep in mind that there is an awful lot of effort out there in looking and developing antivirals, looking and developing vaccines, looking at and developing other ways to avoid this. So those are all positive and encouraging things. I think so. There is hope. And after getting through this first round, we might walk away going, well, we have the tools in our toolbox that we can at least slow this down and buy us time. And right now, the game plan is buying time until there's a vaccine out there, until there are effective antiviral drugs. For people who still succumb, new and better approaches to care management are all going to be important. And one of the silver linings might be after now 40 years of reducing funding for public health, perhaps we might start realizing that there are some real reasons to support preventive as opposed to reactive care.
Jon for president.
Not enough coffee out there. So I think we've taken enough of your time already. So thank you very much. And if you have questions, shoot them my way. I'll try and answer them.
Thank you so much, Jon.
Thank you. Bye-bye.
Take care now. Bye-bye.